How do we diagnose SARS-CoV-2 infection? There are three tests available for diagnosing SARS-CoV-2: RT-PCR, rapid antigen tests, and IgG and IgM antibody tests. Originally, the diagnosis was primarily made by reverse transcriptase polymerase chain reactions, abbreviated RT-PCR, sometimes referred to as the molecular test. Within a week of identifying the outbreak in Hunan, China, Chinese scientists published the full sequence of the virus shown schematically at the bottom of this slide. Using this sequence, short probes spanning parts of the RNA messages for the production of the spike protein, arrow, the nucleocapsid, envelope, RNA polymerase protein were all created. The sample is first treated with reverse transcriptase, RT, to synthesize the complementary DNA sequence from the viral RNA. As compared to RNA, which can quickly degrade, DNA is stable and will not break down during repeated heating and cooling. Each heat and cool cycle doubles the amount of DNA. The synthesis of sufficient DNA for detection usually takes 2 to 3 hours and 15 to 30 cycles. The higher the virus concentration, the fewer cycles are required to reach the detectable levels. If no viral RNA is present, the reactions will not take place and no DNA will be produced, and the test will be negative. Samples of virus can be collected by swabbing of the posterior pharynx and throat, and more recently by collecting saliva samples, which have proved to be equally sensitive. Because special PCR machines, multiple reagents, and highly skilled technicians are required, this test is expensive, $75 to $120 per test. The results of this test are often delayed. Test values usually do not return for 24 hours. Because unique viral nucleic acid primer sequences are used, the test is highly specific, 99 to 100% specificity. The best RT-PCR test can detect as few as 10 copies of the virus. However, the sensitivity is difficult to estimate because of variability of the sampling method. Nasopharyngeal swab or saliva samples appear to be equally sensitive. Shedding of the virus varies during the course of disease, explaining the relatively low sensitivity of 70 to 80%. This means that in situations where the likelihood of infection is high, because RT-PCR sensitivity is low, false negative tests can occur, and a single test should not be trusted to exclude disease. Originally, many countries had a shortage of tests, including the U.S. Now, with improved availability, many health systems are screening all patients admitted to the hospital to exclude asymptomatic carriers. Aggressive testing, combined with contact tracing and isolation, are the ideal approach for controlling an outbreak once the number of daily cases becomes manageable. The second very useful test is the antigen test. Rapid antigen tests are becoming more widely available, including home tests. This test detects a viral protein. Most tests use an antibody that binds to the nuclear protein. When the antibody binds to the viral protein, it attracts a fluorescent dye that results in a fluorescent light signal, or the antibody is immobilized on a plate using the same principles as the pregnancy test, and this is the method used for home testing. When the test bar turns black or red after exposure to the sample, instead of being pregnant, you are infected with the SARS-CoV-2 virus. Because results come back in 15 minutes rather than several days, this is the ideal screening tool. These tests detect 120 to 150 viral particles as compared to PCR, which can detect 10 viral particles. However, as described earlier, most infected individuals have millions, even billions of viral particles in their nasal secretions and saliva. The specificity and sensitivity of the antigen tests are slightly lower than PCR. These tests are 1/2 to 1/3 the cost of RT-PCR and do not require laboratory expertise. They can be conducted within 15 minutes and are called point-of-care tests because of their rapid turnaround. Antigen tests are now the preferred method for screening and can be conducted at home. In developed countries, including the U.S., antigen tests are widely available. This is the ideal test to use to identify asymptomatic carriers so they can be prevented from spreading the virus in the family or other large gatherings. Finally, a word about antibody testing. This test will be helpful as an epidemiology tool, but because IgG and IgM antibodies usually take 7 to 14 days to rise, this test is not recommended for diagnosis. As shown in this graph, the vertical axis is the quantity of antibody and the horizontal axis time in days. The lower blue line shows the antibody response of someone with mild disease as compared to someone with severe disease, the green line, which results in the production of higher levels of antibody. This test can be used to determine the prevalence of disease in a specific location. Now let's look at the time course of viral shedding and how this relates to test positivity. This graph is adapted from a publication from the Journal of the American Medical Association, JAMA. As depicted by the red line, which represents live virus, it generally takes 3 to 4 days after exposure for sufficient viral growth for RT-PCR to detect the virus, shown in the blue line. In the case of the Omicron variant infection, the incubation period is often shorter, 2 to 3 days. RT-PCR will detect virus earlier than the antigen test, which is also depicted by the red line. But the problem with molecular tests, they often remain positive for several weeks after live virus is no longer present. The RT-PCR is detecting residual RNA released from the dead virus. The antigen test, on the other hand, detects intact live virus, closely approximating the same red line. Finally, the concentrations of anti-IgG -green line and anti-IgM antibody -purple line are shown. You can see they both begin to increase within 10 to 14 days of onset of symptoms. IgM comes down over the first 1 to 2 months, while IgG can persist for months to years. Is there a better way to identify early cases of COVID-19? Can a rise in core temperature be used as a pre-screen prior to ordering a PCR or antigen test? Could each of us take our oral temperature 1 to 2 times every day to establish a basal core temperature and to identify the early onset of fever and COVID-19? To answer this question, let's go back to the pathogenesis of the virus. When the virus binds ACE2 receptors, it stimulates danger detectors that identify foreign virus and bacteria called toll-like receptors, specifically TLR2 and TLR4. Also, when the virus replicates its RNA in the cytoplasm of cells, this foreign RNA stimulates 2 other TLRs, TLR7 and TLR8. TLRs activate a signal cascade that induces the production and release of cytokines, specifically TNF, IL-6, and IL-1 beta, known to stimulate a rise in body temperature, inducing fever. Therefore, based on this understanding, the prediction is that when the virus infects respiratory epithelial cells and macrophages, it should induce fever, and this would be expected to be the first sign of disease. Based on analysis over 1,000 patients, we found that monitoring temperature for 72 hours or longer, fever was detected in the majority of cases as the first manifestation of COVID-19 and was present in 73% of patients infected with the wild-type and alpha variant viruses. Here are some samples of my personal temperature monitoring. My basal core temperature is 97.5. If fever is defined as a rise in core temperature of 1.8 degrees Fahrenheit or 1 degree centigrade, then if my core temperature reached 99.3, I would have a fever. As compared to the set temperature to define fever, 100.4 degrees Fahrenheit or 38 degrees centigrade, this approach increases the ability to detect fever by approximately 25%. During periods of high infection activity, I recommend everyone monitor their temperature at home. If fever is detected, immediately isolate from others and conduct a home antigen or go to a testing center for RT-PCR testing. In summary, RT-PCR is the most specific and also the most expensive test. It has a slow turnaround time and should be used predominantly for diagnosis and treatment. Antigen testing is less expensive. It has a rapid turnaround time, but is less sensitive and specific. It should be used for screening. Antibody testing shows a delay in increase in IgG and IgM and should be used to determine the number of cases in an area or the prevalence. It should be used for epidemiologic studies. And finally, core temperature monitoring for fever is equivalent in sensitivity to antigen testing and can be used as the first step for detecting the onset of disease.